Up next is a radiotherapy special session. To open this session, please welcome Professor Teresaa Sy-Ortin, Director of Benavides Cancer Institute and Chair of Medical Radiation Committee at University of Santo Tomas Hospital. She is also the head of the Department of Radiation Oncology at University of Santo Tomas Hospital and Manila Doctors Hospital, Philippines.
Good evening, ladies and gentlemen. Our next session is a panel discussion entitled Recent Advances in Precision Radiotherapy, IORT, Tomotherapy, Cyberknife, MR Linac, Proton Beam Therapy, and others. Our first panel speaker is Professor Katsuyuki Karasawa, Director of Radiation Oncology, Department of Tokyo Metropolitan Cancer Center, and Infectious Disease Center, Komogone Hospital. He is a founder member of the Japan-Taiwan Radiation Oncology Symposium, National Project Coordinator of RAS project of IAEA, Principal Investigator of JROSG 10-2, Faculty Member of IORT, and Faculty Member of Accurate Exchange in Radiation Oncology. Our second panel is Dr. Dang Hui Quoc Thinh, AOS board member and Vice Director of Ho Chi Minh Oncology Hospital in Vietnam. He is the head of the Department of Radiation Oncology and head of Palliative Program in HCMC, Vice Secretary General of HCMC and also Pain Society, and Executive Council member of the Asian Clinical Oncology Society. Our third panel speaker is Professor Jinsil Seong from the Department of Radiation Oncology in Yonsei University Hospital, Korea. She is one of the few who pioneered radiotherapy in hepatocellular carcinoma. She has served as president of the Korean Liver Cancer Association and is currently the president-elect of the Asia Pacific Primary Liver Cancer Expert Association. Our last panel speaker is Dr. Mirriam Joy Calaguas, who is chair of the Department of Radiology of the Philippine General Hospital. She serves as the National Project Coordinator in Radiotherapy of the International Atomic Energy Agency. She is the National Project Leader in Radiation Oncology for the Forum for Nuclear Cooperation in Asia, and she is also the Vice President of the Federation of Asian Organizations in Radiation Oncology. Ladies and gentlemen, please welcome our distinguished panel speakers, Professors Katsuyuki Karasawa, Dang Hui Quoc Thinh, Jinsil Seong, and Mirriam Joy Calaguas. Thank you.
Good evening, everyone. My name is Dr. Mirriam Joy Calaguas, a radiation oncologist from the Philippines. I would like to thank the AOS for inviting me to be one of the panelists in this evening's session. So the title of my talk is an overview of the status of advanced radiotherapy in Asia, the Philippine experience. The past decade has shown impressive developments in image-guided radiation therapy, IGRT, IMRT, stereotactic body radiation therapy, and proton beam therapy, which have allowed the delivery of highly conformal radiation treatment plans with reduced planning margins. My presentation aims at surveying these technological advances in the context of the vast continent of Asia with a particular look in the Philippines. A gap has clearly emerged when we talk about access to and the availability of radiotherapy services across the continent between developed countries and countries that belong to the low to middle income bracket. This gap is apparent even in basic radiotherapy services and is more pronounced when it comes to advanced radiotherapeutic modalities. This table shows the availability of certain radiotherapy technologies in different Asian countries. Even a glance at this table highlights these gaps. For example, Japan, with a population of around 120 million, has 848 radiotherapy centers, while Indonesia, with a population of 255 million, only has 45. Approximately 51% of all linear accelerators in the region are in China, which of course has the greatest population. Fortunately, all the countries on this list have at least 3D conformal radiotherapy capabilities, and majority have capabilities for IMRT, with the exception of Cambodia and Laos. Only half, however, have equipment for intraoperative radiotherapy. 3D planned image-guided brachytherapy is available in 14 of 19 countries on the list. 5 countries have no access to stereotactic radiosurgery, and 4 have no access to stereotactic body radiation therapy. Of 19 countries on the list, only 5 have operational proton beam radiotherapy centers. There is not much data on the utilization and availability of MR Linacs or PET-CT simulators in this region. Radiation treatment, which is particularly useful in head and neck cancer, pediatric oncology, and cases of re-irradiation, with its physical property of rapid dose fall-off. It allows even more conformal treatment plans with minimal irradiation of the organs at risk, compared to even advanced IMRT delivery systems. The so-called gap is apparent. The data presented here is from the Particle Therapy Cooperative Group. There are currently 25 proton beam centers and 9 carbon ion centers in the continent. There are only 5 nations with proton beam centers and 3 with carbon ion centers. More than 70% of the proton beam and carbon ion centers are located in Japan. Half of the proton centers currently under construction are in China. Taiwan has 2 proton beam centers and 1 carbon ion center, with 2 more centers either being planned or already under construction. Singapore and Thailand have at least 1 currently under construction. Of the 27 proton centers currently being planned or constructed, 93% are in countries which already have existing and operational centers. In the Philippines, an archipelagic nation with a population of 100 million, there are 49 centers operating. Majority of these are located in the major urban centers around Manila and Cebu. There are 53 Linacs and 6 Cobalt-60 units in all. Of the 49 centers, only 39 have IMRT capabilities. Of these, only 13 use 3D image-guided external beam radiotherapy. 12 centers perform intracranial stereotactic radiosurgery, while only 5 are capable of SBRT. 8 centers are able to do 3D image-guided brachytherapy, mostly for gynecologic or prostate cases. Only 2 centers have IORT. In terms of advanced teletherapy machines, there are 7 Tomotherapy units, 3 variant TrueBeam, and 1 Halcyon. There is currently no proton beam or carbon ion center in our country. A 2018 IAEA study demonstrated that the Philippines has an optimal radiotherapy utilization rate of 53%, defined as the proportion of all cancer patients who would benefit from radiotherapy at least once. The actual radiotherapy utilization rate, defined as the proportion of cancer patients who actually receive radiotherapy, was placed at 10%. Thus, the country has an 80% unmet need for radiotherapy services. This means that 8 in 10 cancer patients who would have otherwise benefited from radiotherapy do not receive such treatment. Equipment availability is not the only limiting factor. Human resource problems also contribute significantly to this gap. At present, there are only 99 practicing radiation oncologists in the country to serve a rapidly growing population of 100 million. The numbers are clearly inadequate. This is further complicated by geographic, economic, and political factors. Furthermore, the full impact of COVID-19 on radiotherapy service delivery is also an important question with no easy solution. Finally, there is a need in each country and the region as a whole for an in-depth analysis of economic, social, and cultural factors and their interactions, which are critical to bridging the inequality gap in terms of access to both basic and advanced radiotherapy. It cannot be denied that most of the advances in radiotherapy technology have to a large extent disproportionately benefited wealthier societies despite the greater cancer burden in low to middle income countries, as I have tried to show in this short presentation. However, great progress has already been made, but much more still needs to be done if we want the fruits of the technological advances in radiotherapy to be more equitable. Efforts such as this virtual conference organized by the Asian Oncology Society are much needed positive steps toward the bridging of the gap. Thank you very much and good evening.
So everybody can hear me? And can you see the slide? Okay, then I will start. Actually, this presentation is supposed to be followed by Dr. Karasawa after he does wonderful presentation showing the current precision radiotherapy. My part is application of precision radiotherapy for hepatocellular carcinoma. So after my presentation, I think Dr. Karasawa will be ready. So we had gone through two big changes in radiotherapy of liver cancer. First, conceptual change from whole liver radiation to focal liver radiation. So that led to a need for dose escalation. Earlier in 2002, my group reported dose response in hepatocellular carcinoma shown in the left panel for the first time. The higher the dose, higher the tumor response at the cost of toxicity. Then Dr. Toya group from Japan also reported better survival outcome by higher dose of radiotherapy shown in the right panel. So the issue is how to deliver high dose with less toxicity. So now we have a remarkable technological evolution which make it possible to high dose radiation for focal liver. And then this part will be more detailed explained by Dr. Karasawa later. But briefly, we could deliver high dose radiation on tumor more conformally while avoiding surrounding normal tissues. So from 2D, 3D, and then now cutting edge technology, IMRT, SBRT, 4-dimensional RT, and charged particle therapy, with the same tumor volume, we could reduce normal tissue radiation more significantly. Now let's take a look at therapeutic option by stage of hepatocellular carcinoma. For early stage, radiotherapy is applied as curative aim, SBRT. Now even for SBRT, people thought the hepatocellular carcinoma seems radiosensitive, but we found that biological effective dose higher than 100 gray brings better oncology outcome, not only in local control, but also in overall survival. This data has just been published this year. There's a typographical error, not 2000, but 2020 year, this year. For advanced HCC, in case of tumor confined to liver, which is locally advanced tumor, then radiotherapy can bring better outcome in combination with other therapies such as local regional therapy like TACE, transarterial chemoembolization, or regional chemo or systemic treatment. We reported a multi-center study on radiotherapy for portal vein tumor thrombosis, showing combination mode as well as higher dose, at that time higher than 45 gray, as significant factors for better outcome. Now, most importantly, conversion of locally advanced cancer to resectable region might be possible by radiotherapy. Currently, we try to deliver higher dose, higher than 60 gray in BED using IMRT. Now we analyzed high dose group with IMRT with low dose group with the 3D conformal RT. This figure shows just one example how we deliver high dose to the tumor core. Then we reduce the dose in the periphery area so that avoid proximal, the GI tract in proximity. As you can see in this slide, higher BED group, higher than 72 gray, showed better oncology outcome, not only in local control, but also in overall survival, shown in the left panel. This difference shown again in after Prof score matching. In the right panel, you can see that local failure frame survival, overall survival, higher in high dose group compared to low dose group. Then what about toxicity? We examined grade 3 to 4 level toxicity. As you can see here, toxicity was similar except thrombocytopenia, which was not that fatal. Finally, most importantly, high BD group showed almost double-fold conversion rate to resection, shown in 20 patients among 101, 20%, versus low-dose group, 64 versus 500 patients, 12%. So this difference was statistically significant. And most importantly, once patients converted to resectable status, resection is done, then survival outcome of those patients look similar to the early stage patients. So taken together, precision RT allows dose escalation, which further improves oncologic outcome. And this is advertisement of the upcoming very important conference dealing with the hepatocellular carcinoma tumor immune microenvironment. It will be held in this weekend, virtual conference. They can cover liver immunology and use of checkpoint inhibitors in combination with anti-VEGF and TKI, and assessing responders, and also keynote speakers for tumor immune microenvironment. And there's also a role of local therapy in tumor immune microenvironment, and the role of chemo and radio and external beam RT will be covered here. And I'm also a speaker for this session. So I can recommend you to join all in this important meeting. Thank you for your attention.
Oh, yes. Oh, okay. This is my slide. Okay. Can I? Yes. Thank you very much. Good evening, the audience. I'll talk about the progress of high precision radiation therapy. I'll skip my slides. This is my conflict of interest. And the next slide, please. Next slide. There are mainly two types of high precision radiation therapy. The first one is stereotactic radiation, and the second one is intensity modulated radiation therapy. But both techniques need highly precise image guided radiation therapy techniques, IGRT. I'll talk about IGRT later. And both techniques are gradually covering the other technique. Okay, next. By definition, stereotactic radiation therapy called stereotactic external beam radiation therapy and stereotaxic radiation therapy is a type of external radiation therapy that uses special equipment to position the patient and precisely deliver radiation to the tumor. And what differences stereotactic from conventional radiation therapy is the precision with which it is delivered. For brain, around 1 millimeter, and for the body, 5 millimeter. Next slide, please. Next is this is an example of SBRT, brain mets, lung cancer, liver cancer, spinal mets, and kidney, prostate, and so on. Next slide, please. Next is IMRT. By definition, thin beams of radiation of different intensities are aimed at the tumor from many angles. This type of radiation therapy reduces the damage to healthy tissues near the tumor, especially concave shape target volume can be irradiated with this technique. Next, this is an example of IMRT. Left-hand side is lung cancer and the right side anal cancer. So the doses to heart and those to the intestines are greatly reduced. You can see. Next slide, please. This is background for the development of HPRT. And that one is radiation therapy treatment planning was performed using CT scans. And second one is improvement of diagnostic imaging technology. And the third one is the improvement of computer calculation speed. And the fourth one is miniaturization of accelerators. And the final one is satisfaction of manpower. Next slide, please. CT was developed in late 60s and has been utilized in radiation therapy in the early 80s. Since then, radiation therapy has been considered volumetrically. And beam view technique has been developed and three-dimensional conformal radiation therapy has been developed. Next. Like this slide, we use CT simulator and we can do treatment planning like 3D-dimensional conformal radiation therapy. Next slide, please. Yes, this is improvement of computer calculation speed. As you can see, in 10 years, computer speed has been getting almost 1,000 times faster. Next slide, please. Owing to the improvement of computer calculation time, the development of other modalities, CT has been utilized more in radiation therapy, especially in the 21st century. First example, fusion technique. You can make treatment planning more accurate. Next slide, please. Next example is 4D CT. You can observe internal movements more accurately. This would help in planning moving targets such as lung cancer and liver cancer. Next example is a Beam CT-based treatment verification. Just before the treatment, the Linac can take CBCT and at the same time compare it with treatment planning CT, and you can adjust the positioning errors, and accurate treatment is performed. Next, please. The last example is adaptive radiation therapy, monitoring the shape of the target normal tissue in serial CBCT. The shape of the target would often change like this slide. Therefore, it is necessary to replanning during the course of the treatment. Taking Beam CT has such a benefit. Next slide, please. Summing up these examples, there are many kinds of image-guided radiation therapy. IGRT can provide very accurate positioning of the target and normal tissue, and it is a very crucial point to perform high-precision radiation therapy. At the treatment planning, image fusion technique and 4D CT technique can provide very accurate treatment planning. And at the treatment, various kinds of modalities are contributing very accurate delivery of radiation beams. And in near future, online adaptive radiation therapy would be realized using MRI taken at the treatment position. Next, please. Miniaturization of accelerators has been contributing to the progress of HPRT. Small accelerators can be installed, for example, in a ring-shaped country, and very stable and accurate treatment has been realized. Next, please. Satisfaction of manpower is also contributing to the progress of HPRT. This slide shows the increase in the Japanese Board for Medical Physicists qualification. As you can see, just after the year 2000, the number of qualified medical physicists has been increasing very rapidly. It is very much consistent with the development of high precision radiation therapy in our country. Next, please. This slide shows the historical calendar of HPRT. As for treatment technique, SRS has already initiated in late 60s, and after the utilization of CT, 3D CRT was initiated in early 80s, and in the middle of, or late 90s, IMRT and SBRT was developed, and it has been routinely used at the present time. And yes, as for machines modalities, Gamma Knife was developed in 60s, and IORT was also introduced 60s. Proton therapy was initiated in the 70s, and carbon ion radiation therapy was in 90s. Cyberknife and Tomotherapy was introduced around the change in the centuries, followed by Vero for the RT and MR Linac. And the second part of my talk, I will introduce, next slide please, introduce machines and modalities briefly. And first of all, I will introduce IORT. Next slide, please. Next. And IORT is not a machine, but a technique. Next, please. IORT has merits of concentrating high doses to the target volume while minimizing the dose to the nearby located critical organs. Combined with surgical procedures such as intestinal bypass, decompression of spinal cord compression can alleviate the patient's symptoms also. And it can finish with one treatment, and it can spare healthy skin tissues in breast cancer. And as for demerit, demerit, usually only one treatment, no fractionation merit, and more aggressive treatment than external beam radiation therapy. And those distributions not so precise compared with SBRT at this moment. Next, please. Next slide, please. Next slide, please. Okay. Current indications are as follows. Breast cancer, colorectal cancer, pancreatic cancer, soft tissue sarcoma, and spinal mets. Next slide, please. Next is Cyberknife. Cyberknife is a dedicated stereotactic machine, and as in this slide, small linear accelerators is inside, and with two pairs of X-ray monitoring systems, the motion of the tumor can be monitored very precisely. And with tracking system, it can perform tumor tracking treatment as well. And Cyberknife has many strong points. Next slide, please. Like this, sub-millimeter accuracy, dose distribution advantage, sharp dose gradient, high maximum dose inside the target volume, while sharp dose follow-off outside the target volume. And next slide, please. I will, I'm in a hurry. And it has those distribution advantages like this. And next slide. Next slide, please. And this next is Tomotherapy. Tomotherapy is also a unique machine. And next slide. Next slide, please. It has a merit of rotating accelerators with a set of binary collimators can produce unique IMRT dose distributions. Extremely long field in craniocaudal directions can be taken so that the whole body irradiation can be easily performed. And the MVCT can give treatment verifications. Next slide, please. These are the indications, typical indications: lung cancer, head and neck cancer, lung cancer, prostate cancer, skin tumors, and whole body bone marrow irradiations, and whole CNS irradiations, and so on. Next, please. Next is MR Linac. Until quite recently, MRI would be affected by electromagnetic field produced by linear accelerators. However, by the complete shielding of EMF, we can take MRI before and during the treatment. Next slide, please. MR Linac has some merits compared with other Linacs. It has higher tissue contrast compared with CT. That's better to do treatment setup, and it is able to monitor tumor and healthy tissue during the treatment also. And owing to the tissue contrast, it is relatively easy to perform adaptive radiation therapy. The future prospects for online ART. However, it is rather costly at this moment. And next, please. And next, please. At this moment, pancreatic cancer and the prostate cancer would be the good target for MR Linac. Next, please. This is a proton treatment. Next is a proton treatment. Proton beam is accelerated by synchrotron to the 100 MeV level. As you know, proton beam has its black peak here, and we use proton beam by spreading out black peak. Next, please. Proton therapy. Next, please. Proton therapy has advantage over photons by its dose distribution. It can make anterior part of the normal tissue and low in dose, and at the same time steep dose fall off in the lateral and posterior side of the tumor. Therefore, lower integral dose can be expected compared with photon IMRT and other techniques. The disadvantage is high installation cost and high running costs. Next slide, please. Typical indications is for lung cancer, and on the right-hand side, medulloblastoma for the adolescents. Next slide, please. And this slide shows the indications of proton therapy in our countries. Childhood cancers, prostate cancer, bone and soft tissue tumor, non-squamous head and neck tumors are currently reimbursed. But in near future, lung cancer, liver cancer, esophageal cancer will be reimbursed. May I skip some more slides? Next slide, please. Next. 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 So in summary, various high precision radiation therapy techniques has been developed at the end of the previous century, and radiation has been realized with curative intent in the majority of cancers. The technique which are called IMRT, SBRT, and so on. As for its background, improvement of the diagnostic imaging technology, computing speed, saturation of manpower, and development of brand new promising machines. The development of small size accelerators would realize more stable HPRT, and there have been developed many brand new machines. Several promising treatment machines and techniques are introduced. Thank you for your kind attention.
Thank you very much. I think
Yeah.
we have a very excellent panel for today, despite the glitches. We're sorry, our professors, that we had some problems, but in the end, we were able to listen to a very interesting talk on precision radiotherapy, both from Dr. Karasawa and Dr. Seong and Dr. Mirriam Calaguas. So we do not have any questions from the audience, but may I know, Dr. Karasawa, what do you think is the most exciting development in radiotherapy
What
among all the
most
available?
I see. Any I think SBRT is promising. Combined with IMRT, it can induce immunological reactions, and really with checkpoint inhibitors, I have experienced abscopal effects already. So in future, maybe many more patients can be cured with such a cutting edge technique.
Okay, thank you very much.
You're welcome.
Dr. Seong, you have a very interesting work in radiotherapy for HCC. What is the next step in using it as a primary treatment for HCC in combination with the other modalities?
Well, yes, that's very good question. Well, for the early tumor or small tumor, already SBRT proved as a curative role. We even compared SBRT and RFA, and they show that similar outcome, and that the result has been published in Journal of Hepatology already. And then for the advanced stage, still radiotherapy needs some combination strategy, and I think that Dr. Karasawa's comment is very, very important. Now we are entered into immuno-oncology era. So if we make a good combination with kind of SBRT or hypofraction schedule with a checkpoint inhibitor, then we can make tumor control much better at the same time. Maybe we can expect abscopal effect. So I have a question to Dr. Karasawa. You
Yes.
already experienced abscopal effect.
Yes.
What kind of fractionation schedule did you use?
For SBRT, we used 50 gray in 10 fractions, in 5 fractions.
15 gray.
50 gray in 5 fractions, let's say 10 gray fractions times 5.
Okay,
for
I see.
Metastatic lymph nodes
Okay.
from pancreatic cancer. But it really diminished the unirradiated tumor. So
Okay.
I believe in abscopal effect.
Okay.
Now.
Congratulations. Now there's a very hot discussion about what fractionation schedule will be the best in case of combination with immune checkpoint inhibitors. So people say moderate hyperfraction will be the best instead of a high dose SBRT like 15 or 20 gray at 1 fraction.
Yes, I agree. And important thing is not irradiated broadly so that immunologic potency is not decreased. Do you think so?
I agree, but I think that this time is too much limited to extend our discussion.
Yeah.
Yes. there is
please discuss it.
so much excitement in precision radiotherapy. I have a question to Mirriam. What do you think would be the best way to synchronize treatment facilities? Because I think even in our country we see a super, modern technologies in one center and some centers with very limited facilities.
Yeah, thank you, Dr. Teresaa, my colleague from the Philippines. First of all, good evening to everyone, and I would like to greet my co-presenters, Professor Karasawa and Professor Seong, for very excellent lectures. I enjoyed listening to all of them. For how to synchronize the facilities, I think we can work through our societies. Is that what you mean, Dr. Teresaa? Yes, we can work together, have a network of communication so that we can, because there are centers like, for instance, in the Philippines, there are centers with advanced technologies, but other centers have just very basic radiotherapy. This is not only in the Philippines, but in Asia in general. We have the facilities in like proton beam, carbon ion, they are just in 5 to, let's say, 7 countries. So maybe we can have a linkage with these countries so that, for instance, from the Philippines, we can communicate with Korea, Japan, and we can send patients if we need to avail of the high precision radiotherapy equipment. Not only with patients, but also in terms of maybe we can also link with each other in terms of education, training, and that's why this is not an advertisement, but I'd like to mention here that we have an organization called the Federation of Asian Organizations in Radiation Oncology. There are about how many 14, 15 countries now, and we can interlink with each other in this way. So synchronization, yes, we can share what we have, technology, education, and also patients, particularly patients. So the world is getting smaller in that sense.
Great comments.
Great comments. Yes, I agree.
Mirriam has actually championed that in that aspect, the education. So
Why you ask me?
much, I think we all agree that it has been an interesting hour despite the glitches. Thank you very much for the excellent panel discussion. Have a good night.
Thank you
Teresa.
very
Thank you.
much.
Bye-bye.
Thank you for your time.
Bye.
Bye bye.